The next speaker is Dr. Jia, Dr. Yan Jia. She's an OBGYN doctor who has been conducting in-depth research on recurrent miscarriage and recurrent implantation failure. Her research has received numerous grants from the National Natural Science Foundation of China and from her provincial science foundation. Dr. Jia has also been the lead investigator of 3 major government-funded reproductive endocrinology projects in China. Let's join her for her talk about the ERA to RIF patients with immune dysregulation. Thank you.
Good afternoon, dear Professor. It's a great honor to share our experience on ERA and the endometrial immune assessment in RIF patients. We have performed the endometrial immune assessment for RIF patients as well as ER tests as our routine in our center. As both these 2 type tests are aimed at patients with recurrent implantation failure, in addition to considering the displacement of the window of implantation, we will also pay attention to the endometrial immune environment of RIF patients. So we perform 2 tests for RIF patients while taking the endometrial biopsy. One is ERA and the other is endometrial immune test. The definition of RIF is currently not yet unified. In China, our center defines RIF as failure to achieve pregnancy after 3 or more times of transfer cycle or transfer at least 4 good quality embryos in women under the age of 40 years. The incidence of RIF is usually 10 to 15%. The reasons for RIF mainly include 2 aspects, embryo and material factors. Because of the restriction of PGTA and leaks obligation in mainland China, many RIF patients are not able to legally use PGTA or leaks for embryo screening. So we can only use embryo morphology score or time lapse to evaluate the quantity of our embryos. Second, we will detect the material factors of RIF patients as follows: chromosome abnormalities, uterine or pelvic abnormalities, infections, endocrine issues, blood coagulation factors, then immune factors, and personal window of implantation. Immuno and ERA are our main screening declarations for unexplained RIF patients. For unexplained RIF patients, we may also perform EMA and ALIF tests. For the endometrial immune environment, we evaluate 80 types of endometrial immune cells, include NK cells, Treg cells, NKT, macrophages, dendritic cells, plasmacytes, and so on. We tested the quantitative count of endometrial immune cells. ERA is one of our most commonly tested for endometrial receptivity assessment. The pre-sample and clinical effectiveness of the ERA test have been introduced by previous speakers. So here I want to show some data from our center in China. We can see that nearly 60% of RIF patients have a pre-receptive one-day result, who need to delay the transfer for 24 hours. 15% need to postpone the embryo transfer for 12 hours, and only 19.9% don't need to change the time whose implantation failure may be caused by other factors. There are very few patients who need to delay the transfer for 2 days or 12 hours in advance. We compared the clinical outcomes between the with patients after ERA and without ERA. And we found that personalized embryo transfer after ERA can significantly improve the pregnant rate of blastocyst transfer. Pregnancy rate is 67% versus 39%. Implantation rate is 46% versus 16%. Cumulative pregnancy and implantation rates are also significantly higher in ERA group. This data is the first report in mainland China of ERA test and has not yet been published for now. So the conclusion is that ERA can improve pregnancy outcomes with patients, but for the patients who are still not pregnant, what should we do? So let's share our 2 cases. The first case is 28 years old woman who has failed implantation for 3 times of blastocyst transfer. According to our routine screening of RIF patients, there was a little problem with her immunocell indicators. The NK and CD8 T cells were also increased, and her window of implantation was pre-receptive 1 day. So the diagnosis for this patient is endometrial immune dysregulation and displayed window of implantation. For her first transfer, we will feel that early intervention may affect her window of implantation, so we didn't interfere with her endometrium. Then she transferred 2 highly quality blastocysts with the ER suggestion, but unsuccessful implantation again, so it's very early. But at the same time of the 5th transfer, we consider that her failure might also be caused by abnormal endometrial immunity. So we performed intrauterine perfusing of dexamethasone therapy on her FET cycle, then transfer according to the ERA suggested time. At the same day or after the transfer, her HCG was positive. So at present, the patient has been pregnant for 16 weeks and everything is really relatively stable. So it makes very happy for us patients. And that's one case. Let's move to the second case, who had 4 times failed implantation. Like the previous patient, she had no other abnormalities. 2 types of endometrial immunocell at no level, Treg and macrophages. ERA result is to postpone 24 hours. So in this first transfer cycle after ERA, we proceeded to the blastocyst transfer according to the protocol of ERA result. No interfering with her endometrium, but this implantation was also failed. Then to the 5th transfer, we performed 3 times intrauterine perfusing of GSF during the FET cycle, then transferred according to the ERA and successfully pregnant. Now the patient has been pregnant for 20 weeks and everything goes well. Therefore, we can conclude that endometrial immunotherapy can be supplemented for patients who failed implantation of ERA. This is our data of RIF patients, ERA plus endometrial immunity group versus ERA group. The implantation rate was 48.2% versus 41.2%. Clinic pregnancy rate was 58.6% with 56.3%. Although there is no statistical differences, we found that the ERA plus immune group has a slight increasing trend in pregnancy rate. Therefore, we will enlarge the sample size to see if combined immune intervention is more effective in improving the pregnancy rate of RIF patients. If we assumed that endometrial immune tests and intervention are beneficial to patients, why it happened? The scenario of endometrial immune assessment comes from the fact that embryo implantation requires the balance of matter and fetal immunity. Endometrial immunity is crucial to the maintenance of implantation and pregnancy. Before and after pregnancy, the local immune cells of endometrium are extraordinary differences between and after the routinization. The implantation period and the non-implantation period, such as NK cells, were increased to promote angiogenesis, and Treg cells will be remained at a certain level to maintain immune resistance. Endometrial immune cells play important roles in aspects of implantation, including implantation, fetal embryo tolerance, as well as the angiogenesis and trophoblast effacing. From macro perspective, the immune environment of endometrium will also change greatly. In the first trimester, endometrial immune cells shows a pro-inflammatory state. In the second trimester, maintaining the immune balance in the body is conducive to the immune tolerance of pregnancy. In the third trimester, the immune cells will be in a pro-inflammatory state to initiation of labor onset. In the process of pregnancy, there may be problems in embryo pregnancy due to insufficient excessive inflammatory reaction. Abnormal microenvironment can induce and strengthen the cascade reaction of inflammatory factors in early stage of pregnancy or delivery process, lead to adverse pregnancy outcomes, such as recurrent implantation failure, recurrent miscarriage, preeclampsia, premature delivery, cervical insufficiency, intrauterine growth retardation, and so on. So we need to detect whether the expression of each endometrial immune cells is in the normal range. We detect 80 types of immune cells. Let us first talk about the first important type of endometrial immune cells, NK cells. Its surface marker is CD56. During the window of implantation, 65 to 70% of decided immune cells in the endometrium are natural killer cells. Its functions are facilitate embryo adhesion and implantation, induce the establishment of immune tolerance, regulate trophoblast migration, enable angiogenesis and remodeling, protect the uterus from infection as an important part of elite immunity. From the middle luteal phase to implantation to early pregnancy, NK cells increased gradually from 5% to 25% to 70% in early pregnancy. So NK cells are very important immune cells in the process of pregnancy. If there is a problem with immune function, the level of UNK cells in the endometrial overweight patients is significantly abnormal. Some of them are too much and some of them are too few. As too few or too much may cause recurrent implantation failure. The second type of immune cells into macrophages. Its surface marker are CD68 or CD163. Its functions are immunodefense, regulation of trophoblast dividing, regulation of angiogenesis, and induction of immunotolerance. The third important type of immune cells is regulator T cells. Its surface marker is FOXP3, which plays a major role in protection of embryo when mature embryo cells first contact fetal antigens and associate with invading trophoblasts. Its functions are upregulated during the window of implantation and early pregnancy. Passivity in pregnancy immunoregulation inhibit effector T cell proliferation and downregulate adaptive immune response, and repair muscular trauma from angiogenesis and assist embryo implantation. Abnormal level of Treg cells in endometrium, either too few or too much, may be related to implantation failure. The fourth type is CD8 cells, T cells. In the macrophageal interface decidual tissue, CD8 T cells are the most numerous T cells and play the key role in pregnancy process. Its functions include promote embryo implantation and trophoblast cell invasion, maintain the balance of immunotolerance at the maternal-fetal interface, and resist pathogenic microorganism infection to maintain a long immune microenvironment at the maternal-fetal interface. The endometrium of both recurrent miscarriage and recurrent implantation failure patients shows a statistically significant increase of CD8 compared with normal pregnant group. The last one are dendritic cells. The surface marker is CD1A. About 1% to 2% of immune cells in the deciduum are dendritic cells, DC cells. Dendritic cells participate in the formation of endometrial decidualization and immunotolerance microenvironment, and can also affect the invasion and migration of trophoblast cells. Its functions are antigen presentation, induced immunotolerance, and angiogenesis. The endometrial leaf patients shows a statistically significant increase of CD83 and a decrease of CD1A compared with control group. Therefore, to assess these important functions of immune cells, we designed a detection of endometrial immunocells by using multispectral imaging digital pathologic analysis system to analyze whether the expression of these immunocells is normal during the embryo implantation stage in the middle uterine phase. The expression level of endometrial immunocell molecular marker in uterine metaphase in a reasonable range is related to a good outcome of embryo implantation and later embryo development. Adjusting the expression level of endometrial immunocell molecular markers to the target value is beneficial to improve the pregnancy outcome of free female. But how to treat the abnormal endometrial immunoenvironment? We use intrauteral perfusing of GSF, HCG, dexamethasone, or immunosuppressants, such as cyclosporine, methotrexate. The effective rate of our treatment was 66.7%, and the effective rate of endometritis was 88.7%. We were wondering about whether the endometrial immunotreatment would affect the application of ERA results, so we compared one patient. After our routine endometrial preparation, the result of the first time ERA test was 133 hours after progesterone intake. When the second ERA biopsy, we performed intrauterine perfusing of CSF for her, and her window of implantation was still 133 hours after progesterone intake. So the two cycles ERA result is the same. But why didn't we take a second biopsy for her? Because her embryo transfer was a failure after the first time with ERA test. Then the second time we want to perform intrauterine perfusing treatment because it did have problem of endometrial immunity. To be cautious, we performed another ERA biopsy in the same period of perfusing treatment. Then we have confirmed that this treatment would not affect the window of her implantation. So in the following treatment, we are very relieved to do this treatment for her. Through our comparison, the result shows that our intrauteral perfusing treatment doesn't affect the window of the implantation. So how do we arrange the transfer with immunotherapeutics and ERA test for patients? We will perform ERA biopsy for patients in HRT cycle or down-regression HRT cycle or natural cycle. We will take more endometrial samples to the ERA test as well as endometrial immunocell examination. If endometrial immunocells shows abnormalities, we will perform immunotreatment for patients in the next transfer cycle. Immunotreatment will be based on the abnormal endometrial immunocells detected by us. After oral or medication or intrauteral perfusing treatment, embryo transfer was performed according to the recommended optimal time of ERA. There was a poster about the clinical outcome analysis of ERA combined with immunotreatment. The results suggested that the treatment based on the endometrial diagnostic might improve outcomes compared with empirical management. The study also found that 71% of rape patients had at least one abnormalities if ERA and endometrial immunocell tests were performed at the same time. The pregnancy rate of personalized embryo transfer after immunotreatment and adjusted transfer time was 52%. So we're also wondering if immunotreatment can improve the pregnancy rate of RIF patients in more studies. Recently, we also found another paper of ERA combined with Endometrial Immune Assessment. Its conclusion is that the pregnancy rate of recurrent loss and the RIF patients who underwent an ERA or scratch test was 55%. There were more Tregs, similar UNK cells, and trend toward normal CD16 UNK in the endometrial women with an ongoing clinic pregnancy compared to that in non-pregnancy women. No statistically significant difference between ERA non-receptive and ERA-receptive endometrial in the endometrial NK and Treg density. So, in the end of my presentation, I would like to introduce my conclusion. Both ERA and endometrial immunotherapy can be effective methods to improve endometrial receptivity. The current cases analysis suggests that intrauterine immunotherapy before utilization doesn't affect patients' window for implantation. ERA in combination with endometrial immunotherapy could improve IVF outcome of RIF patients, but clinical study with larger sample size is still needed. We will continue exploring the methods to improve the pregnancy rate of RIF patients. So, thank you for listening.
Okay, thank you very much, Dr. Jia. Okay, we actually have quite a few questions from different countries, but we don't have a lot of time, so I'll try to. Let's start with the first question. The first question was as the statistical data of ERA results showed that in your slides, only 20% of the patients showed a receptive profile. What are the characteristics of the patients that you choose for the ERA test?
My criteria for ERA test are many RIF patients who have experienced at least 3 times implantation failure or failed pregnancy after more than 4 transfer with high quality embryo. Because as I mentioned before, we have limitation to perform PGTA or LICS. There will be chances of aneuploidy embryos, even though those embryos were considered as good quality from morphology's point of view. This is my thoughts, and I don't have the evidence to verify without PGTA or LICS. Therefore, we have some patients even performed PET, but they are not yet able to achieve pregnancy.
Okay, thank you. I think we have the last question. We only have 1 minute. Okay, so the last question we're going to answer here is that regarding the 2 cases that you presented, have they performed the immune test and treatment before transferring with the ERA?
For my 2 cases, the patients didn't perform the immune tests or immunotherapy before ERA. The immune test and ERA test were performed from the same biopsy sample collection. We didn't apply immunotherapy in the first PET cycle, but in the second PET cycle. And as a result, both these 2 patients achieved successful pregnancy, which leads us to think the immunointervention in combination with ERA test could work effectively together for RIF patients to achieve pregnancy.
Okay, we also we still have 3 questions from Australia, from Korea, and from China, mostly about the your protocol. But we will loop the questions to you, and then we will provide the answers to the doctors that asked the question. Thank you again, Dr. Jia, for your very comprehensive presentation. Thank you.